Good afternoon and a very warm welcome to this session. So this is session I, parallel session, and we're going to talk about models of observational studies in Europe. So it's about methods on how to measure indicators that helps us to see whether we're doing okay on the way to eliminating a viral hepatitis and ending HIV among people who inject drugs. I'm Thomas Seller. I work at the EMCDDA, that's the European Monitoring Center for Drugs and Drug Addiction. It's an EU agency. And I'll be co-chairing this session with Ruth.
Hi, I'm Ruth Zimmermann. I'm working at the National Public Health Institute of Germany, at the Robert Koch Institute, and mainly in hepatitis C and vulnerable populations.
Thanks, Ruth. And so the way we will organize this session, so we will have, I will do a short intro, and then we'll have the real interesting stuff with our speakers that we will introduce in a moment. It will be 10 minutes presentation, and then we'll have time for short questions or a few questions straight after the presentation, and then we'll have more time at the end of the session for more discussions and online as well as face-to-face questions. Is it okay? Yes, now it's okay. So if you allow me, I will start with a brief intro. So I'm a chair, but I'm also briefly presenting this session. And I'm going to talk about some of the data that we monitor at our agency or at a monitoring center among people who inject drugs. So we have what we call for viral hepatitis, for example. That's one example of our products. We call it the elimination barometer. It's been, we updated it last week, so if you Google EMCDDA elimination barometer, you will have access to that data. So it looks at a series of indicators based on the WHO plan, 11 of them, specifically focusing on people who inject drugs, and how countries of the EU, as well as Norway and Turkey, are doing in terms of reaching these targets. We have contextual information, the data itself in tabular format, and the related WHO targets. And in this brief intro, I'm going to focus on 3 types of indicators, namely prevention, continuum of care, and impact, to see, well, how are we doing, but also their limitations and how observational studies can and should support the monitoring among this key population. So the first family of indicators is related to prevention and harm reduction specifically. So the main ones, you might be aware of these, are the what we call the NSP coverage, so the number of syringes, clean syringes distributed per person who inject drugs per year, and the OAT treatment coverage, opioid agonist treatment. So in terms of NSP, the target for 2030 is at least 300 clean syringes should be available per person per year. The 200 target that was set for 2020 and for, I believe, also 2025 has been reached only by 5 countries in the EU and Norway. So many countries are lagging behind that target. In terms of OAT, it's a bit better. 14 countries, as you can see on the right-hand side of that slide, have reached a target of 40% of people who need OAT are on OAT. But put together, because we know that combined prevention works better, if you look at both targets combined, only actually 4 countries have reached both those targets with our latest data, that is 2021 or latest. And these countries are Luxembourg, Norway, Czechia, and Greece. And actually these indicators are based on programmatic data, right? So we estimate the total number of syringes distributed by the Ministry of Health. We divide it by the estimated population size per country, and we come up with those, I would say, macro crude estimates. And they tell us little about regional, local differences, and also about people's needs. And that's why observational studies are also should be used more widely to provide information on those type of indicators. And by the way, countries that are doing quite well in terms of those macro indicators for NSP coverage have experienced local HIV outbreaks among their key population of people who inject drugs, namely most recently Finland and Greece. In terms of continuum of care, so the 2030 targets, again, this is published by WHO. 90% of people with chronic hepatitis C are diagnosed, and 80% of these are treated with the latest effective medicine. And the concept of the continuum of care, as you may know, comes from the HIV field. So when you want to apply it to HCV, it's a bit more complex. It's actually quite tricky because you have a short treatment course, you have clearance, reinfection. So applying the HIV model to HCV is a bit complicated. That's the first thing to say. The second thing to say is the ideal theoretical solution would be to have access to electronic records of all patients being treated and cleared for infection. And actually accessing those databases at the national level is quite difficult. And even identifying people or patients based on their risk factors is also very tricky in most of the EU countries. So that's why we rely at the MTDA mostly on snapshot, I would say snapshot cross-sectional continuum of care proxies embedded within seroprevalence studies or surveys among people who inject drugs, observational studies again. And you can see two examples here. The one at the bottom shows the one lately produced by the Czech colleagues, where they recruited more than 1,000 people accessing needle exchange programs in Czechia, tested them for HCV and asked them whether they've been ever diagnosed in the past and whether they've been ever treated for HCV. And only 43% of those who responded they've been diagnosed with chronic HCV have actually been treated. The last indicator I want to focus on briefly is the impact for HCV. The WHO target here is less than 2, so it's an absolute target. We're aiming at less than 2 incidence case per 100 people who inject drugs by 2023. So here, I mean, the easy solution would be to rely on notifications of new HCV, but that's not a solution because of the nature of the disease and the notification data we have in Europe. It reflects more the testing activity rather than real incidence rate, so that's not an option. We have data, we have studies that actually estimate incidence, and we'll have an example from Greece and Stockholm in a few minutes. But we rely more on monitoring prevalence of viremic infection over time, and actually that's one of the proxy WHO indicator for that particular indicator, and the target is that 80%, or there should be a decrease of 80% by 2030 of viremic prevalence among our key population. And as you see, we have not much or not many data regarding this indicator. We have 3 countries, namely Greece, Austria, and Norway, providing some trends over time. And Norway has almost reached the target with a 68% reduction in viremic prevalence among their population of people who inject drugs. So one of my main messages based on those 3 slides is that we should implement, or we should take the opportunity of observational studies to collect better data to document the progress towards elimination of viral hepatitis and ending HIV. And that's why we started a project with the RKI, with Ruth and Ida at the RKI, to update our current protocol, what we call the DRID toolkit. And this will come with an updated list of indicators, recommended steps for planning and implementing such studies. And also importantly, we are keen to document best practice of observational studies that are currently being implemented in Europe. And that's why we have actually set up this session. And we'll have the opportunity today, the chance to hear from people or research colleagues from Sweden, from Germany, Greece, France, and Scotland, who actually implement studies that we think should be promoted to give us the information we need to better monitor the situation among people who inject drugs. And the first speaker, the first representative of those research group is Ruth, that will tell us about the DRUK 2.0, which is a German study implemented a few months, a few years ago in Germany, still going on. Ruth, the floor is yours.
Yeah, thank you very much. I'm happy to present some very selected results and indicators of this DRUK 2.0 study. DRUK means in German Drogen- und chronische Infektionskrankheiten, Drugs and Chronic Infectious Diseases study. So I briefly tell you about the study design and the methods. This was a cross-sectional pilot study among people who injected within the last 12 months. We did venue-based recruitment in 23 low-threshold drug services and OST services in 7 different cities in 2 federal states of Germany, Berlin and Bavaria. And we did data collection along with the routine work of the services. So we trained staff of these services to support the data collection among their clients. We collected dried blood spots and tested them in a central lab for hepatitis C, hepatitis B, 3 serological markers, HIV and syphilis. And we had a self-administered questionnaire that could also be supported by the service staff with 40 questions on risk and preventive behaviors, testing treatment history, and so on. And this was a pilot for evaluating feasibility and acceptance among staff and also clients in order to set up a monitoring system which will follow next year and to evaluate the methods for that. And here we can also compare the data with a former study 10 years ago, which was also cross-sectional, also among people who injected in the last 12 months. Slightly different in methods, 8 cities in Germany and recruitment via respondent-driven sampling, but also in low-threshold drug services and similar data collection, but much more extensive. So we have at least 2 data points to compare here. So just to show you some characteristics of the study population of this recent study, that was almost 600 participants, and in the old study, 2,000 participants. The study population was very similar. Median age was 39 years, proportion females less than 1/3 or 1/4, 78% born in Germany. 18 and 16 years since first injection, and all of them, or 84% of them, injected also very recently in the last 30 days. Increasing proportion of current homelessness, up to 34% in the recent study, and a high proportion with history of imprisonment in both studies. And in the following, I will now focus on very selected indicators, and I start with indicators on prevention and harm reduction. So Thomas already said that, of course, there are different indicators that are also used to compare countries. I think the indicators we derive from these studies are more used to assess local measures and so on. So, for example, for the proportion of people who inject drugs who share materials, who use used needles and syringes or filter spoons and water, we asked for that by just asking the question, did you use needle syringes or other materials that were already used by others? And our denominator are the people who injected in the last 4 weeks. So we just asked for very recent sharing. And in this recent study, 14% shared needle syringes and 29% shared filter spoons or water. of those that injected in the last 30 days. For this indicator that was presented by Thomas, needle syringe coverage per people who inject drugs in the last year, we don't derive this data from this cross-sectional survey, but we have another survey to harm reduction services, and we calculate it from this survey. However, the proportion of people who inject drugs who receive opioid agonist treatment, this can be done, as was shown by Thomas, with programmatic data, but it can also be done with a cross-sectional survey. So we just ask people, are you currently receiving OAT? And the denominator in our study are current injectors who answer the question, but it could also be injectors that use opioids, so just those in need. And this was in this current study 61%, quite high for our country. Strengths and limitations with this cross-sectional data. Of course, if it's self-reported, underreporting is always possible. And for sharing behaviors, for example, we think that there might be underreporting. Of course, there's also recall bias. People might not recall if they shared or not. And regarding the indicator on opioid agonist treatment, I think there is under and overestimation possible. It is a biased study population for this indicator because it's not only people in need for OAT, and it's current injectors, so there might be both, in both directions. Coming to another indicator on prevention, HPV vaccination. So in our study, we collected self-reported data on vaccination, and also we measured it. So we looked at anti-HBs from dried blood spots among those susceptible to HPV. So we excluded the infected ones. And we have very divergent data. For the self-reported, 44% told us, yes, I have been vaccinated against hepatitis B, and 32% said no. And for the measured indicator, we saw that 30% had isolated anti-HBs, which is a sign of previous HPV vaccination. However, we know from the previous study also where we compared that the validity of self-reported status is quite low. There is recall bias, confusion with other vaccinations, and for the anti-HBs, there's the limitation also that you need to have a quite high threshold, quite high titer to detect the anti-HBs. So this is really difficult to assess, should we use that data or not, and how should we collect it in a proper way. So coming to the cascade of care, the blue bars are the recent study and the gray bars are the old study. Here we mix self-reported and testing data. We ask people, so the first bar are the measured anti-HCV positives or RNA positives. The second and the third couple of bars are self-reported data. So we ask for, have you ever been diagnosed for hepatitis C, and have you ever or currently received treatment for hepatitis C, which is nice to mix this data. However, there's also the limitation that you can't really distinguish several infection episodes with this data because we just can ask for the ever diagnosed and ever treated. So there's also a limitation in this data. And probably we overestimate the ever infected, the ever diagnosed, and the ever treated also with that. For HIV, it's much more simple. However, in this recent study, we had a very, very low HIV prevalence and only 14 persons infected with HIV. So this is our first column here, 100%. And we asked the question, is it really valid to derive a treatment cascade from such a low sample size? the treatment cascade for HIV is much less complex, so the data quality is probably much better, and it might be used also for regional measures, but it's of course very much dependent also of the study population. The last result is on impact. As Thomas said, it's difficult to derive incidence data. We think that viremic prevalence over time is much more feasible, and you can see here the reduction in viremic prevalence for HCV from 44 to 27%, 39% reduction. So we are not at all reaching the WHO target of an 80% reduction, and we only have 2 time points available, but we see a lot of regional differences, and this is also data that is very useful, again, to assess local measures. So we will roll out this study design next year. We want to set up a surveillance system for people who inject drugs and drug-related infectious diseases, and we will go for this venue-based recruitment, same study population, but in addition also for this first round collect data on people who ever injected drugs, because we want to better assess HIV care, and we will have decided to go for sentinel cities, where we have several sites per city, again low threshold and OST services, around about 200 participants per city, and then we can present indicators by a sentinel city and also overall. And the data collection is planned to be repeated every 2 to 3 years. However, funding is not really secured just for this first round. So take home in terms of prevention, yeah, we see these huge limitations of the self-reported and also of the testing HPV vaccination data. So happy to discuss how we should go for that. And we can also discuss whether the WHO indicator on needle syringe coverage should be derived from surveys to people who inject drugs or from surveys to services. Regarding cascade of care for HIV, we think it's robust when derived from cross-sectional surveys. However, for HCV, it's challenging and it's not very precise, right? And regarding impact, incidence difficult, but viremic prevalence over time is very feasible. Thank you very much.
Thank you very much, Ruth, for this very clear presentation on DRUC study. So we'll take questions, a few questions after each presentation from the floor. So if you have any questions, you can ask them or you can write them on the online app as you wish. I don't see any hands and I don't see any questions online. So thank you again, Ruth. And then I would introduce the next speaker. So Vanna Sipsa, you're a professor at the University of Athens and you're a principal investigator in major community-based programs for people who inject drugs in Greece, among which the famous Alexandros and Aristotle studies that you conducted and are conducted in Athens and Thessaloniki. Vanna, the floor is yours.
Thank you very much. Just first, I will start with the background information about Greece to justify why we designed these programs in this way. So, first of all, in Greece, data and indicators related to infectious diseases, access to harm reduction, and so on are collected routinely, but from people who are enrolled in drug treatment programs. Before 2011, based on this data, we knew that the prevalence of hepatitis C was high. We knew that the coverage of harm reduction was relatively low. And in 2011, we had an outbreak of HIV infection, and that changed a little bit the way that we think about this issue. So we had some problems. The most urgent one was to respond to an evolving HIV outbreak. And the others were, how can we assess these indicators over time? How can we collect these indicators from a wider sample of people who inject drugs, including those currently injecting and not linked to drug treatment programs, and also how we can increase awareness, diagnosis, and linkage to care. So the challenges were, first of all, to reach this population of high risk people who inject drugs who are not linked to other services and have a high risk of infection, transmission, low diagnosis and treatment rates. We wanted to have a very high impact, so we wanted a high population coverage and rapid implementation, and also we wanted also to have this linkage to care component. So we implemented 3 programs, 2 in Athens, Aristotle in 2012, Aristotle HIV in Athens in 2018, and a third one recently during the pandemic in Thessaloniki, the second largest city, Alexandros. So you can see that the sample size was from 1,000 to 3,000 people. All 3 programs had a similar design, and they had 3 main components. First of all, that people were recruited using these RDAs mentioned before by Ruth as well. Well, people recruit other persons to the program through their injection networks. The second thing is that each program was performed in multiple sampling rounds, so people could participate in these multiple rounds. For example, in Aristotle 2012, this was implemented in 5 consecutive recruitment rounds. People were tested, and data were collected from a structured questionnaire, so we had data over time within each program. And also the last component that was common to all the programs was that we incorporated this linkage to care approach. Well, we had arranged appointments, we had peer navigators to accompany patients, and so on. So did we reach the population we wanted to reach? Yes, I mean, the majority were currently injecting, especially in Athens, 81 and 75%, 50% in Thessaloniki. The majority were not currently enrolled in opioid agonist treatment programs, and a large proportion were homeless. And we know that homelessness in Athens as well, in the outbreak, is a risk factor for HIV, and also it doesn't help starting treatment and continuing with treatment. So what did we learn from these programs? First of all, about access to prevention and harm reduction. There were data collected from interviews, so self-reported data, about whether these people were enrolled in opioid agonist treatment programs currently or ever, and whether they have received syringes in the past 12 months, and how many syringes they have received in the last 30 days. So combined with information on the frequency of injecting per day, this could also allow to assess whether they actually fulfill their needs or not. So if you see in this graph some of the results regarding, for example, receiving syringes in the past 12 months, you will see that in Athens the numbers, in any case, the numbers were disappointing, because receiving at least 1 syringe in the past 12 months is something that doesn't mean a lot. So in Athens, around 40 to 50% mentioned at the first visit to the program that they had received syringes. In Thessaloniki, it was only 5%. And also, this is very low proportion of people enrolled to opioid agonist treatment programs. Regarding access to testing and awareness of HCV and HIV status, again, we had data from the interviews combined with HCV and HIV testing data performed during the program. So we asked people whether they have ever been tested for HIV, when was the most recent test for HIV and what was the result, whether they have been diagnosed with hepatitis and what type of hepatitis. So for example, whether they have been ever tested for HIV, these are the results. Only in Thessaloniki, for example, only 57% have report ever been tested for HIV. But the thing is that since people who injected drugs participating in these programs were allowed to participate multiple times, it was possible to assess the awareness of their status over time. So for example, in the first Aristotle, in the 5 consecutive rounds that we performed, sampling rounds, in the first round, only 16% of HIV positive individuals were aware of their serostatus. But at the end, at the final round, this had increased to 85%, and this is normal. I mean, we perform testing in this intervention, but given the very high coverage of this intervention, we understand that the awareness has overall increased in the population of people who inject drugs in Athens. About access to HIV and HCV treatment and overall continuum of care, the data we collect is mainly self-reported data, and I have to agree with Ruth that it's not such a valid information. But we also had data from the linkage to care activities carried out through our program. So we asked people whether they have received, they were currently on antiretroviral treatment, or whether they have received treatment for hepatitis C, either interferon-based or the new treatments, whether they were aware that they were cured from their hepatitis. For example, in the two recent programs in Athens and Thessaloniki, among those testing and the HIV positive, only a very small proportion reports having received treatment for hepatitis C, and I think that's the least information that people could, I mean, it's something that perhaps people can validly report. But we have information about what we achieved from our intervention. So in Alexandros project, where we identified around 400 chronically infected patients with hepatitis C, we were able to identify the social security number for almost all of them, and this is an important information because without that you cannot have access to free DAAs. And out of those, 62% were linked to HIV care, and 52% started treatment with DAAs. What about the impact and overall trends in prevalence and incidence over time? So since we perform testing in these programs, it's easy to assess the prevalence of HIV and HIV infection. And regarding incidence, since people could participate in multiple times and were tested multiple times for HIV and hepatitis C, through these programs it was possible to observe people who were seronegative and became positive. So we were able to observe seroconversions. So in 2012, when we realized that there was an outbreak of HIV infection in Athens, thanks to Aristotle, we were able to see how HIV incidence evolved over time, where we have seen that after all these interventions were implemented, including Aristotle, HIV incidence dropped quite rapidly. And also this was used later on to reconstruct the whole, let's say, epidemic and the incidence during this epidemic using mathematical modeling. In the same way, we try to assess the prevalence of hepatitis C infection and incidence over time. Well, for example, sometimes we have to use proxies, like in the case of this case I'm showing you, where we assess anti-HIV prevalence among new injectors, people who have started injecting in the past 2 years, which is considered to be a good proxy of incidence. And you see that in 2012, almost 60% of new injectors were already HIV infected. And in 2018 to 2020, the levels are quite high again, but lower compared to 2012. But also based on observed seroconversions, we were able to estimate HIV incidence, which was really high in 2012, 65 new infections per 100 person years, and reduced to 14, around 14 cases per 100 person years. But I have to stress that in 2012, this estimate was observed mainly among new injectors. And it has been shown that the incidence among this sample of people who inject drugs is higher. Sometimes we had some unexpected findings during these programs. For example, we identified a large number of deaths, and it's something that we're going to present on Friday. We also identified an emerging outbreak in Thessaloniki of HIV infection. Although we went to Thessaloniki aiming mainly to hepatitis C, we identified another problem that we didn't expect. So we have seen from all these multiple tests that we performed over time that people who were initially seronegative, especially after the first lockdown due to COVID, returned HIV positive. So HIV prevalence increased over time from around 3.9% to up to 9%. And almost most of the cases, as you will see, were newly diagnosed cases, first time reported to the HIV surveillance system. And based on the HIV seroconversions we identified there, we know that HIV incidence is around 7 new cases per 100 person years. And the final thing that it was very useful for us is that we were able to obtain another estimate of the population size of people who inject drugs. Based on this number, a lot of indicators are calculated. So we have annual estimates based on the number of people who enter drug treatment programs, and we wanted to use this new, let's say, data set where we have people who are not necessarily linked to opioid agonist treatment programs. So we used capture again, but this time the multiple sources that we have used were these RDS rounds. So you can see in this graph people who participated in multiple rounds, and this overlap allows us to perform this capture. And we estimated that in 2012, in Athens, there were around 4,000 people who had currently injecting, so this allows us to estimate the prevalence of injecting drug use, but also to see revised estimates about the coverage of needle and syringe programs. We thought, based on the official, let's say, estimate of the population size, that our NSP coverage was good. It was around 200 syringes per person per year, but with this revised estimate, this becomes 97, which is surely inadequate. So in conclusion, these repeated cross-sectional surveys with RDS recruitment and testing and linkage to care, they were originally implemented because we wanted to offer this intervention to the population, but they are very useful in reaching very rapidly high-risk people who inject drugs and assess prevalence, incidence, behaviors in these let's say, hot, high-risk population. We can estimate prevalence and incidence over time. We can estimate the population size or incorporate new data that can help us to have more better estimates for the population size, and also, at the same time, offer a service to the population, offer testing, treatment, and linkage to care. So thank you very much.
Thank you very much, Vana. I see a question, please. Present yourself briefly, please.
Brendan Healy, I'm an infectious disease consultant in Wales. We haven't had very much success with peer referral, asking identified positive individuals to bring other individuals in. So I'm just wondering if you've got any tips for us and whether you think the HIV outbreak had any impact on people's willingness to find other people and bring them forward.
Well, first of all, peer referral in our case was also supported by monetary incentives. I don't know if you have tried that. I mean, in RDS, it's usually incentives are monetary or other incentives are used. So it's very helpful, at least in the beginning, until people gain some trust to the programs. This was very important. After some people, after the first few months, let's say, when people realize that it's something that they can trust and they can have the care they needed, I don't think the incentive was the main reason for coming.
Other questions?
Yes, no, I had the same question, but now I make another one. Is it publicly funded or it's private funded?
Yeah, that's a good question. The first Aristotle in 2012 was publicly funded. It was local money and EU money. After that, no more funding, so we are privately funded by pharmaceutical companies. And that's why we cannot sustain it. I mean, it's something that we do today and maybe in 5 years again. That's a problem.
But I have a quick question, and thank you very much for the presentation. And you showed nicely when you detected this outbreak in Thessaloniki, and you also showed that the national coverage of harm reduction was probably vastly overestimated, or at least for some pockets of populations. And just my question is, after this, were you able to were the local authorities able to scale up basic harm reduction?
Yeah, in Thessaloniki there was a very rapid response, because as soon as we had the first HIV cases and we realized there were new cases or seroconversions that were observed, I mean, during the program we were certain that there were new infections, not just new diagnoses. We communicated the results to the Organization Against Drugs, and they have upscaled the distribution of syringes. But the thing is to have this, to have a steady high coverage, but because even in Athens, although they increase the coverage of needle and syringes, year after year you will see many fluctuations. It's not always steadily high coverage.
Okay, thank you very much, Vana. It's my honor to introduce to you now Marie Geoffrey Roustide. She's a sociologist and a research fellow at the French INSERM Institute, and she leads study among people who inject drugs in France, and she will present to us the Coquelicot study from France.
So hello everybody, so thanks to Thomas and Ruud for inviting me to present to you the Coquelicot study. So I will begin with the story of this study. So the Coquelicot study has been carried out in France for 25 years now. So it is public funded since 25 years, but as a consequence, we are not able to do the survey every year or every 2 years because that's a very, very expensive survey. So the aim of this survey is to monitor trends in infectious disease, HIV and hepatitis B and C among people who use drugs. So before we implemented this survey in the 90s in France, data about the prevalence of HIV, HCV and HBV among people who use drugs were based on self-reporting, non-random samples, and face-to-face interviews were conducted by harm reduction providers and not by external interviewers and trained interviewers. So in 2022, following a pilot phase which began in 1998, we did the Coquelicot study for the first time in one city, in Marseille, in the south of France. We choose Marseille because we know that it will be probably the most difficult setting for implementing a study. So we wanted to evaluate all the difficulties that we may face for implementing this type of survey. So at the beginning, the Coquelicot study was conducted by Institut de Veille Sanitaire, so the French CDC, Center for Disease Control, and it was also supported by Agence Nationale de Recherche sur le Sida et les Hépatites Virales, ANRS, and the survey was carried out in collaboration with Institut National d'Études Démographiques and the HIV Centre National de Référence. So we have done several editions of this survey, and each edition includes a face-to-face questionnaire done by a trained interviewer. But since the first edition in 2022, and to the last compared to the last edition that we just finished in 2023, the questionnaire lasts at the beginning 30 minutes, and now we have a questionnaire that lasts, each questionnaire has a mean time duration of 1 hour and 15 minutes. So that's now a big survey that goes beyond infectious disease. For each edition, we also collected blood sample, and the blood sample have been collected with an auto finger prick, and we put some blood on blotting papers, and after the analyses have been done by the Centre National de Référence of HIV. So regarding the locations of this survey, so we included people in all services that welcome people who use drugs. And we mean people who use drugs who are, we include people who use drugs who are exposed to HIV and HCV. Just after I will define what we mean by exposed to HIV and HCV. So the services that are included for the Coquelicot survey are outreach teams, harm reduction facilities, drug treatment centers, and people were recruited in one city in 2022, in Marseille, after in 5 cities for the second edition in 2024, 5 cities and 2 departments in 2011. In 2013, we decided also to include people who speak Russian. I will explain that just after. And for the last edition, we included 27 cities, and we have 5 different languages. And for each edition, we included between 1,500 people to 2,200 people for the last edition. So the survey is based on a complex sampling plan, including time location sampling combined with the general weight share methods, because the aim of this survey is to produce valid estimates. For the last edition in 2023, INSERM, my institution, so the National Institute for Health and Medical Research, becomes the principal investigator of the study. So INSERM has replaced the French CDC, and it has a lot of impact about the transformation of this survey. So now we transform, for the last edition, a repeated seroprevalence survey in a monitoring survey that has the aim to improve drug policies in general, and in order to enable more favorable environment for people who use drugs, and we go beyond infectious disease. So for each edition, the study has tried to keep up with changes in people who use drugs profiles and practices, and we also try to respond to new challenges in terms of drug policy. As an example, INRS Coquelicot study is not only focused on people who inject drugs, contrary to other monitoring studies that have been presented today, but we are working on a larger population that we called people who use drugs who are at risk or exposed to HIV and HCV. We include people who have injecting drugs at least once in their life, people who have snorted drugs at least once in their lives, or people who have smoked cocaine crack at least once in their lives. So for the 22 and 24 surveys, the inclusion criteria was to be able to speak French, because at this time, more than 95% of people who attend the services, harm reduction services and drug treatment services that we surveyed speak French. But during the third edition in 2011, we realized at the stage, because before conducting the survey, we did for 1 year, each year, an inventory of all services that welcome people who use drugs, and we include between 100 services and 200 services for the survey. And during this inventory, we realized that a third of people who attend harm reduction and drug treatment services came from Eastern Europe in some settings, especially in Paris. So in order to ensure that the study will still be representative, we decided to perform a new sub-study, still called Coquelicot survey, that are focused only on people who speak Russian. And for the fifth edition of the survey in 2023, we decided to extend the survey to 5 languages: French, English, Russian, Georgian, Arabic, according to the migration trends, and to be sure to be representative to people who use drugs who attend harm reduction services and drug treatment services. So I will now present some indicators. Our indicators are globally the same as the drug surveys that I've presented Ruth just before. So for I present here, unfortunately, only the result from 2011 versus 24, because we just finished the data collection for the 23 survey. So regarding HIV prevalence, so in 2011 we have 10% of people who use drugs who were HIV positive versus 11% in 24. For HCV prevalence, it was 44 versus 60%. For antigens of HBV, we only measure this indicator in 2011, and it was 1.4%. And we also try to estimate HCV incidence by comparing two seroprevalence surveys and by using also a biological method. With the comparison of the two HCV to the two seroprevalence survey in 24 and the two seroprevalence survey, we estimate that 4.4 person per year, where that the HCV incidence was 4.4 for 100 people in 2011, and 7.9 for 100 person per year in 24. So regarding at-risk practices, harm reduction and care indicators, so we measure the sharing, having shared a syringe in the last months. So we were very surprised because in 2011 the level was higher. We have 26% of people who declared having shared at least once a syringe last month versus 13% in 24. And the questionnaire was exactly the same. So for reducing desirability base on this topic, we ask at least once to be sure that people who shared not often will also declare that they share syringes, but it was the same in the two editions. In 2011, we decided also to include a new question about difficulties for obtaining injecting equipment in the last 6 months. And in 2011, a third of people who were recruited in harm reduction services and drug treatment centers declared to have difficulties. Regarding OAT access in the last 6 months, in 2011, we have 77% versus 71%. For HCV testing, HIV testing, we asked a question for lifetime, and it was around 90%. And HBV vaccination in lifetime was 61% in 2011 versus 48% in 24. So in our last edition, in 2023, we decided to have additional indicators. So we added indicators on overdoses in the last 6 months, access to harm reduction services, and especially to drug consumption rooms. That is a very sensitive topic in France. Satisfaction with existing services, willingness to use new services. We also have questions about migration trajectories, stigma, violence, mental health and quality of life, and social support and recovery. So in conclusion, the INRS Coquelicot study has considerably improved the estimate of HIV and HCV seroprevalence among people who use drugs in France, thanks to a strong methodology for sampling and also for collecting and analyzing biological data. But beyond this scientific objective, our study has also pragmatic aims. These repeated studies, these Coquelicot studies, help to build drug policies on evidence-based in order to improve the health of people who use drugs, and indirectly, this study help also to support the efforts of harm reduction providers working to reduce risk exposure to HIV, HCV, and HBV for people who use drugs. So indeed, the INRS Coquelicot study has contributed to the involvement of the French public authorities in tackling the HCV epidemic among people who use drugs, with financial support dedicated to harm reduction and care. And the study has also helped to disseminate policies guided by evidence-based data. As I have two examples. So our data have been used for expanding HCV rapid testing, for implementing drug consumption rooms, and also for envisioning gender transformative drug treatment and harm reduction services for women. But this scientific knowledge has also been possible thanks to a strong collaboration and strong alliances between researchers, harm reduction and drug treatment providers, and people who use drugs who regularly participate to the study. So some publication from our team, if you want to go further. And I also want to acknowledge warmly all people who use drugs who took part in the survey, all harm reduction and drug treatment providers, and also all the principal scientific collaborators involved in the different editions, and also ANRS, our major financial and funding support agency. Thank you. And I have no conflict of interest to declare.
Okay, thank you very much, Marie. So we have time for one quick question from the audience. If any questions, you can use the app as well. Okay, so we might have questions later on in the final time for questions. So the next speaker, she doesn't need an introduction really. So it's Professor Sharon Hutchinson from the Glasgow Caledonian University. So Sharon, you lead the program of surveillance in Scotland. You also work for Public Health Scotland, I believe, still.
Yes.
And you provided a lot of evidence recently on the success of the Scottish program to eliminate hepatitis C. The floor is yours, Sharon. Thank you very much for joining the session.
Thank you, Thomas, and thank you, Ruth, for inviting me into your project in this session, even more so given that we no longer sit within the EU. So I'm very grateful to be part of this European session. Which one? Here we go. Yeah, so the survey in Scotland is in the main funded through our public health agency, Public Health Scotland, but we have enhanced the survey through funding from a research grant, particularly through NIHR. And we refer to our survey as NESI, so it's the Needle Exchange Surveillance Initiative. So a bit of context on Scotland, and probably know a lot of the things that have hit the headlines. We're actually updating our kind of working on generating estimates of the size of the population who inject drugs, but I think believed to be in the range of around 15,000 to 20,000 individuals, and that relates to people who are actively injecting. So there'll be a bigger population who are also more stable, not injecting anymore, on OAT as well. And I think the key thing from this slide is to highlight that in Scotland we've got between a moderate and high coverage of harm reduction services, and that's actually quite important in the context of doing a survey in this population, because it means that we can access that group through these services, which is, I guess, different to kind of what needed to be done in Greece. So here's the design. And this is the NESI. We had done surveys in this population for many years, dating back to the early 1990s. But they had been focused in on Glasgow, a key population who are injecting drugs. With that Hep C action plan in Scotland, we managed to go beyond Glasgow, and NESI was really born out of the Hep C action plan, funding from that resourced a national survey of people who inject drugs, because it was really valued for us to have good information on the extent of Hep C infection in that population. But the aims go beyond just monitoring the extent of Hep C infection into other bloodborne viruses, injecting risk behaviours, and uptake of a whole host of services, which I'll not get into just now, but we've got similar data on OAT, naloxone, testing and so on. And it's a repeat cross-sectional survey. It's voluntary and anonymous. So we are not testing people and returning their results, testing them anonymously, but we do refer them to sites, often which are either co-located or very close for them to go and get a BBV test. We recruit a large number of sites across the whole of Scotland, so around 50% of sites that are providing injecting equipment, and also they will be providing other services such as OAT as well in these settings. And we do that through a team of trained interviews that will administer a questionnaire I've got here short. It's grown over the years. And also undertake the dry blood spot test, which is routinely tested for Hep C and both antibody RNA and HIV, and on occasion for Hep B as well. And we also, the survey is eligible to all those who have ever injected drugs, but by the nature of it that we're recruiting individuals in settings providing injecting equipment, of course we're capturing those that are actively injecting. And we do put a limit on those that have injected in the past over 6 months ago, because we're really trying to understand kind of recent infection. So here's just a comparison of kind of some of the key characteristics of Nessie to other surveys. And we aim to obtain a sample size around 2,000 to 2,500 individuals, which is on par with these other surveys you see in Australia, England, and Canada. But of course, Scotland's a much smaller country, so it actually represents a much larger proportion of our injecting population, probably in the range of something like 10 to 20%. So it does mean that we can get a reasonable understanding of infection, not just at a national level, but also a local and regional level, and we can drill down into these data. And we achieve that sample through this group of trained interviewers, which I've already said administers the questionnaire and dry blood spot. Not sure whether we would achieve those sort of numbers if we were to do it through, the alternative ways in other settings. So that's been really key for us to have a team of interviewers that could go across the country, and it does take about 12 months to complete this survey. We're out in the field just now. So I said before, the focus has really been about hepatitis C, but we have tested for HIV, and it's really been really important for us to do that, because through that, Nessie was really important for us to capture this re-emergence of HIV infection in Glasgow City. So testing for HIV in the local community was actually quite low, so it was difficult to kind of really get a handle on the extent of HIV infection once we were alerted to the HIV outbreak. So Nessie really was valuable in understanding the extent of the rise of infection, looking at the factors that really contributed and related to a transmission of HIV, and also was able to look at intervention coverage and look particularly at the extent of testing in this population. That was a key thing that was scaled up along with treatment in the community in relation to the HIV outbreak. So on hepatitis C, we can also drill down in our data in terms of not just at a national level, but a local area here. You can see on the left-hand side here, we've got data showing the self-report of HCV treatment over time through our series of surveys. And Tayside is a particular area where there's been a programme of work there to really achieve very high levels of treatment among people who inject drugs, and a programme to try and reach Hep C elimination in that area. And you can see in that Tayside area from that very far left that treatment was indeed scaled up amongst the eligible population and achieved the WHO targets of 90% diagnosed and 80% treated in that. And indeed, we can break this down for other health boards as well, and it does vary by region. And there's progress in other areas apart from just Tayside. And much of that progress has been achieved, and you can see on the right we captured data on where people have been treated, and there's been a big push in terms of rolling out treatment away from hospital settings out into the community. You can see from this graph how that really you can see the correlation through the scale-up of treatment associated with treatment delivered out in community in prison settings. And here are some data showing the impact of that scale-up of treatment we can see amongst a Nessie population. I've just focused in on Tayside here, and these are data that were actually presented last year from our NIHR epitope study. And on the far left there, you can see how prevalence is, pre-DAs, we're getting around 30% prevalence of Hep C RNA in the whole population. And since the scale up of treatment following the introduction of DAs. We've seen a drop in RNA prevalence down to around 10% in the last survey, 2019-2020. And in the middle panel here, you can see it also, if you look at those that have got antibodies and the levels of RNA, which is another really important marker for us to kind of look at as well. You can see the prevalence has dropped to around 20% for those that have got RNA. And the modelling work, you can see what, we've tried to kind of estimate what would have happened if DAs hadn't happened, and you can see the shaded areas represent the counterfactual DAs that had not been introduced, and which is an impressive reduction we see from the observed data. And on the right-hand panel here, then we can translate that and estimate that we've got a kind of high probability of having reduced prevalence around 60 to 70%, falling short of this 80% WHO target. But this is an approach that can be used in other settings to measure whether we're achieving that 80% reduction in HCV RNA amongst this population. And just to summarise where we are at the Scotland level here on the left-hand side, we've achieved this by 2019-2020. We're out in the field just now, so hopefully I'll have some result very soon to kind of update where we're at with this. But we've achieved for Scotland around 50% reduction in RNA at the population level. And that compares similar to other settings like England and Australia, who have also scaled up hep C treatment in their injecting populations very much through scaling up in community settings. So this is a really important measure and marker, I feel, for us to be able to guide what progress we've achieved already in elimination efforts. It can guide not just on a national level or country level, but it can guide at a regional level if you've got sufficient numbers. And here, if I can just touch upon our data that we've got from this survey as well. It's obviously a cross-sectional survey, but we could generate some estimates around the incidence of primary hep C infection. We haven't got data here presented on reinfection, of course, which we now need to consider as well, but this is just primary infection. And you can deduce this through either looking at the extent of individuals that have very recently acquired infection, antibody negative, PCR positive here, or you could look like others have done in terms of looking at the prevalence of infection amongst those that very recently commenced injecting. And here you get similar estimates actually across the surveys through these sorts of approaches. But the key thing is you need a massive sample in order to find these people who've very recently acquired infection. That's an example on the right-hand side here. We've got to recruit around 2,500 individuals in order to find between 10 and 30 individuals that have, very recently acquired infections. It's not possible to kind of drill down using this method to regional estimates. And clearly, you don't demonstrate as much progress as what we've seen through looking at the other data I've just shown you on prevalence. I dare say, like others, we're going to have to combine this with other data, model it to really get some more accurate estimates on incidence. So, key points. Our survey has really been really instrumental for us in terms of monitoring infection among people who inject drugs, and really important for us to evaluate how the effectiveness of our interventions. As pointed out, large sample really required to kind of generate estimates of incidence of hepatitis C, but really it's been really valuable us being able to test our samples for RNA and can really track what progress we're making at a national and local area in terms of hep C elimination among people who inject drugs. Thank you.
Thank you very much, Sharon. Great work. Any questions from the audience? Yes?
Thank you very much. It's amazing what you achieve in Scotland. Always very jealous of the data that comes out of there. I suppose the question is really, is that achievable though across everywhere? And if it isn't, what might we do in a simplified form to achieve something acceptable? I'm from Wales, in case you forgot.
Yeah, well, we're probably getting into the discussion session later. Yeah, it's a challenge, and I think like others have pointed out, it's expensive doing these. These are cross-sectional surveys which are cheaper, however, than cohort studies. I would say that. So that's why we've not had a survey every year. And so it is a case of, I think, trying to work out what's feasible for your area, whether you go down to a sentinel basis. We've been able to do it at a national basis because really we had considerable investment through the Hep C Action Plan. So I do think it'll be a case of, for settings that are maybe not able to do a national survey like this, maybe it's possible to boost it and do some sentinel service in kind of key areas. And also, I think, we'll need to be looking at other data sources. So we will need, I think, to ultimately combine it through routine data. So Wales should have a very good routine data on people that are coming through, getting tested. And so that we presented a slide there showing, a marker of looking at RNA amongst the overall sample of people who inject drugs, and we also looked at RNA amongst those with antibody. So that's going to be a key measure I think we can use and look within our routine data sources as well. So like anything with kind of these, I think it's going to be a case of we need to, I think with this, it's trying to highlight, we shouldn't forget about prevalence because there's such an interest with WHO targets on incidence. I think where we can, we should try and strive to do these surveys, but I think we will need to combine it with other routine data sources that are available.
Thank you.
Thank you. Further questions? No. So I think we continue with the last presentation from today. I'm happy to present Martin Karberg. I'm not sure about the pronunciation. He's a senior consultant in psychiatry and addiction medicine and an infectious diseases researcher at Karolinska Institute in Stockholm. And he focuses in his research on HIV and hepatitis among people who inject drugs. And he's also the medical supervisor of the Stockholm Needle Syringe Program. And I think his presentation will focus on that.
Thank you so much, and thank you, Thomas and Ruth, for inviting me to this session. Just a brief background about Sweden. We do know that the population is 10.5 million, but then the data is not so solid anymore. But regarding people who inject drugs, no solid data, but a range between 8,000 and 25,000 people. People with opioid use disorder, no solid data, but maybe approximately 20 to 30 individuals. The same with opioid agonist treatment, no really solid data, but approximately 6,800 people on OAT. What we do know is that we have a low coverage rate compared to the rest of Europe, with only 65 per 100,000. When it comes to prevalence of HIV among people who inject drugs, also no exact data, but approximately 1.8%, and for hepatitis C, 25%. What we do know, though, is that Sweden was the first country in the world to reach the 90 target regarding HIV in 2015. And one success factor was the use of the National Quality Register, INFCA HIV. And in this graph, you can see how we follow CD4 rates and CD4 levels and HIV RNA, and also in this graph, indicate what kind of treatment the person is currently on. So we use this software to introduce a quality register for the needle syringe programs in Sweden, and this started in 2013. So far, we have included 15,000 individuals, and so far this year, over 5,000 unique individuals have done over 43,000 visits. And I will explain this graph in detail in a few slides, but this is the overview of one single person. But of course, you can also pull out aggregated data on prevalence, incidence, and other indicators. So basically, there are some pre-filled questionnaires, and when you are enrolled in the program, there's a 34-item questionnaire regarding social demographics, drug use history, self-perceived hepatitis and HIV status, other social demographic data, and risk behavior when it comes to injecting drugs, but also sexual risk behavior. Then every visit, we ask last injected drugs, and we also have a count on how many needle syringes we deliver, and we're almost in the national coverage of 300 needle syringes per person a year. So we're really close to the WHO targets. And then we have follow-up interviews every 3 to 6 months and at 12 months. So there's also some other indicators. We do take venous blood tests every 3 to 6 months. We follow vaccination coverage, treatment, HIV, hepatitis C, naloxone distribution, and some other area of interests. This is an example of how the 3 to 6 month questionnaire looks, and it focuses on housing, income, livelihood, injection frequency, injection risk behavior, and contact with other services. So this is not only a quality register, it's also a decision tool. So when we look at this graph, for example, and we see the individual in front of us, we can make decision on what to provide, but the beauty is that we can also follow data over time. So this is, So this is all the visits at the needle syringe program. This is self-reported risk behavior that we follow over time, every 3 to 6 months. This is tests for hepatitis, in this case hepatitis A. This is vaccination for hepatitis B and COVID. Hepatitis B test, hepatitis C test, positive hepatitis C test before treatment, and after treatment, a negative HV RNA that we follow over time, and a lot of HIV tests. Introduction of intramuscular naloxone that we switched to nasal, and this is the time the person was on OAT, in this case buprenorphine. We can also focus on hepatitis C treatment for this patient. We start treatment, we clear the infection, but also notice reinfection. We treat again, reinfection after cleared virus, spontaneous clearance this time, reinfection, and now this person is in treatment again. So I'm going to show you some data from the Stockholm needle syringe program. And just so you get an idea of the setting, we have 2 fixed sites, 1 mobile unit. We see approximately 1,800 unique individuals every year. That makes approximately 20,000 visits. The viremic hepatitis C prevalence in 2017 was really high, 55%, and we had a high level of HCV incidence, corresponding to 22 per 100 person years. There's a mix of heroin use and amphetamine, so it's 43% using amphetamines and 43% using opioids, mainly heroin. 25% are women, and 21% are homeless. So over time, we've seen hepatitis C prevalence decrease. We started 2013, and at that time, the viremic prevalence was 63%. That had decreased, as you can see. But the beauty here is that we also can see when we started treatment for all in 2018. And the major decrease in prevalence was from 2018 up till now. And going from 63 to 22% prevalence is actually a 65% decrease. We also looked at incidence, and for hepatitis C, the incidence around 2013 was 19 per 100 person year, and we follow all incident cases. New cases, seroconversions, but also all continuous reinfections. So it's not only the first infection. And over time, we've seen a significant decrease in incidence, now corresponding to 12 per 100 person years. So we're far away from the WH goal. For hepatitis B and HIV, a decrease in prevalence for hepatitis B, but overall a very low incidence rate. And at this time, we have, like other needle syringe programs in Sweden, pretty much full vaccine coverage when it comes to hepatitis B. Prevalence of HIV is particularly high in Stockholm, but we see a decrease and also here a very low incidence rate. There are, of course, some strengths and limitations to this fantastic system. We have a very high population coverage. We cover pretty much 96+% of all people accessing needle syringe programs in Sweden. And we have a high coverage of bloodborne viruses and testing and demographic data. So it's a great surveillance tool. It's continuous surveys and continuous surveillance. We can look at trends over time. We have data on how risk behavior changes over time. We've now introduced some targeted mandatory fields to improve quality in the register. Talk about limitations. Well, a major limitation for these data and for harm reduction in Sweden overall is the NSP legislations. So we still require proof of identity to access needle syringe programs. This is an open cohort, convenience sampling with all those limitations, but we believe it's a good proxy for prevalence and incidence data over time. At this point, we have some limited access to bringing out data in real time, but actually today I signed a contract for improving this, and in 12 weeks we're supposed to have access to a dashboard where we can play around with data and we can look at incidence in relation to gender, most injected drugs, and so on. And that was exactly 10 minutes. So thanks a lot.
Thank you very much, Martin. Very impressive. I mean, it's a dream for many epidemiologists to have such a system. Any questions from the audience? No? So Martin, you can join the panel, and it's 6 past, so we have another bit less than 10 minutes to open the floor to more questions or things or clarifications. I'm also looking at my online tool. And while you think of questions or read your notes for questions, maybe I start with questions. There was a point made but these studies are expensive, which is true, but we've seen in 2 instances they actually detected large outbreaks. And another component, maybe that's for Vanna, you have a strong intervention arm to the study itself. Not to speak about Martin's system, but in your system you're able to link many people to care. Could you just remind us the number of people that you were able to link in both Athens or Thessaloniki, if you have them on your mind?
What I can remember is the most recent example in Thessaloniki with the HIV outbreak, because it was really difficult to link HIV patients to care, because it was during the period of COVID and infectious diseases units where it was difficult even to approach the hospital. But we managed with a lot of persistence, and also with peers accompanying HIV positive patients, to link almost out of 65 HIV positive, I think we didn't link 5 or 6. We linked most of them, but they were very willing to be linked as well for HIV. They even called us from time to time to see when is my appointment, why the other person has an appointment and I don't have one. For hepatitis C, I don't have the numbers, I don't remember the numbers, but although we provided everything on site for hepatitis C, they were not so
eager to start treatment, as in the case of HIV.
Thanks, Vanna. Ruth.
Yeah, I have a more technical question to Sharon. Sharon, you mentioned that you have a very good coverage of your sample, and you can also present the data for by regions. And I was wondering, I've seen the presentation of a colleague in the previous session from Oslo, also a cross-sectional study that is repeated over time, and he also showed data by gender and by other strata. And I was wondering, should we, in our protocol, should we also, so are you also looking continuum of care by gender, by whatever, by age groups also? And should we describe this also in the methodological part, that we have to calculate same sample size for these different strata? Because I think it's important to look at women, for example, viremic prevalence over time by gender or whatever.
Yeah, I mean, I think for the Scottish survey, our main consideration is getting data for all of our health board areas. So we got in mainland Scotland anyway, we don't go into the islands, but in mainland Scotland. So with the samples with the national sample we've got, you generate a very high sample for Glasgow. So it's we try to marry up the distribution with other indicators of which we have on the spread of the injecting population across Scotland. So that's why you have a sample of 900, say, from the Glasgow and Greater Glasgow area, but you'll have in some of the other more rural and smaller health boards, you're getting actually down to quite small numbers. So you do try to achieve, I'd say, at least a sample between 50 and 100 in these smaller health board areas. But so that's been our biggest motivation, is to kind of ensure that we get reasonable data across all of our key geographical areas, because these health boards have responsibility for managing infection and delivering services. So that's why the data is really primed to that. I think in terms of targeting, I guess it'll really depend on what your research question is, or whether you would go to a different strata. But the injecting population obviously changes over time. Our injected population has really aged over time. And we are getting fewer into that group who have recently injected drugs as well. We see a shrinking in that. So you've got to be careful, I guess, to target certain strata, because you might actually conceal some changes in the kind of evolution of that population as well, if you were to do that. I think it really... I'm not sure about maybe pinning down strata into all of these groups, but maybe it needs some consideration.
Thank you, Sharon. Yes, I see. Matt, you have a question.
Yeah, I had a couple of questions, if I'm allowed, but I start with one. I'm interested in, I think these are great examples of ongoing public health surveillance, but obviously are often unachievable, as others have said, in every single European country. But also the other thing that I'm interested in is how you put those data together with other information, because you know that your surveys are not wholly representative, they're partial pictures. I mean, Martin's is brilliant, for example, in terms of people who are in contact with harm reduction services, but then there's a whole bunch of other people who are at risk or at lower risk of hepatitis C. And it's how you can think about, how do we put these data alongside your other data so you can measure or confirm whether what you're seeing in your data is also true of the whole picture in terms of change in viremia, change in incidence. And the other thing I wanted to... So that's one question, is that how do you put your data together with other sources, in particular routine information on hepatitis C testing from multiple sites, which most countries would have? And then can you say why do you think the WHO chose Hep C incidence as its measure when none of you can measure it very well?
Okay, to me. So maybe the aim of this project is actually, so what these studies were selected because somehow they were better than others at being somehow representative. They were not documenting micro-elimination, if you see what I mean. However, you're right, they need to be, they're not enough, they need to be put, like I'm thinking of the French example, right? So INSERM is also doing big record linkage from the health insurance database at the national level. So it's what Marie presented is RDS, so I would say more people that are not necessarily accessing mainstream services, whereas the people who will be in the database of the health insurance would be their own OAT, and they would provide complementary information covering another few thousand people in the French population. So it's not enough to have only those cross-sectional studies. We should also promote other study designs, looking at other target populations. I agree. Yeah, Marie, you want to add something? You have two more minutes.
To answer to this question, for France, for example, our survey is representative of people who attend harm reduction services and drug treatment, and that's why it's very difficult for us to do the survey very regularly, because it requires 2 years of preparation for having a strong sampling plan. But there are several other surveys, smaller surveys conducted at city level, for example, with respondent-driven sampling that might add also complementary data, especially for hidden population. For people, I think that the main problem that we have, especially in several countries, is to have information of people who inject drugs and who don't attend harm reduction services, and respondent-driven sampling can help.
Okay. Sharon, last words.
Yeah, I think what Matt's getting at, and also what Marie's getting at as well, is actually what's the definition of the population that we're actually measuring here? We use the term people who inject drugs, and it's quite a broad spectrum as to the meaning, and we all probably have used it in a different way today. But I think, you know, in terms of WHO targets, is we have focused in these surveys, I think rightly, in terms of a lot of the people who are actively injecting, but there's a broader population there which we are not probably representing here. But we might need to translate the data and combine it with other data sets to generate estimate of the wider population who are at risk of infection at some point. So perhaps I'm not explaining myself fully, but I do think we need to have a better understanding of the population that we're actually trying to monitor here.
Okay, thank you very much to all. So we're reaching the end of the session. So we will be documenting at the EMCDDA those study protocols and the main steps to implement them in other countries. That's what we want. So keep an eye on our website. Thank you very much to all speakers for your time and work and studies. So a few housekeeping messages. So the next session is in the plenary. It's about supervised drug consumption facilities, examining the paradox, and that starts in 3 minutes. So see you there. Thank you very much, and have a nice conference.